Yesterday I had two sessions. In the first session I was talking about how cervical cancer prevention interventions are scaled up in low and middle income countries across the world. And I was emphasizing that the human papilloma viral vaccination, which is one of the important strategies for cervical cancer prevention, is being scaled up currently in 70 countries. And compared to the pace at which human papilloma virus vaccination is being upscaled is much higher than the pace at which hepatitis B vaccination was scaled up in about 10-12 years back. So this is a very encouraging sign, and I was emphasizing that HPV vaccination is probably one of the easiest things to scale up in national health services because of the existence of the extended program of immunization infrastructure. And every country with a high risk of cervical cancer should look into the possibility of scaling up HPV vaccination targeting 10 to 14-year-old girls. On the other hand, although screening is a very important intervention for cervical cancer prevention, it requires a very highly well-organized health services, with sufficient number of providers, the infrastructure and access to diagnosis and treatment, and a good information system to monitor. So unless these things are in place, unless there is an efficient health services are in place, screening programs are difficult to scale up. So the countries which are planning to introduce screening programs probably think of introducing HPV testing as a primary screening procedure, and at the same time they should start improving their healthcare infrastructure so that they can implement an effective screening program. And I was also suggesting, at a pragmatic perspective, the best way to control cervical cancer is to vaccinate 10 or 11-year or 12-year-old girls with HPV vaccination, 2 doses at 6 months apart or 12 months apart, and provide at least a single HPV screen between 35 and 39 years. And if resources permit, they may repeat another HPV screen after 10 years. Such a strategy will rapidly bring down cervical cancer incidence and mortality in low and middle income countries. When HPV vaccines came into the market, they were very expensive. Like any new product comes into the market, it is expensive. And as time goes on, when the demand increases, when the competition comes in, I think eventually the prices come down. There are mechanisms by which low and middle income countries can implement HPV vaccination at considerably lower cost than normally one perceives. For example, the Gavi eligible countries can use the Gavi route. HPV vaccine is a Gavi eligible vaccine. Gavi purchases at a rate of $5 per dose and distributes to the countries, to the Gavi eligible countries. So the Gavi eligible countries can apply to Gavi first to introduce a demonstration program to show how HPV vaccination can be integrated in their health services. And following that, with the successful demonstration of the demonstration program, one can scale up HPV vaccination. The Gavi non-eligible low and middle income countries can negotiate in a bulk purchase and negotiate. I'll give you a very good example. In the American region, which comprises North America, Central America, South America, and the Caribbean, 7 out of 8 girls have access to HPV vaccination through their national immunization program. This is possible because the Pan American Health Organization, which is the regional office of the WHO in the American region, has a revolving fund. And through the revolving fund, they bulk purchase HPV vaccines for the whole region. So when they bulk purchase, they have a better price. They were purchasing at a rate of $15 per dose initially, and very recently I hear they have renegotiated the price, but I don't have the details. So this is a mechanism by which the Latin American countries like Mexico, Argentina, and many of these countries have benefited. Okay, so the access has dramatically improved. See, the access is very low in Asia because only very few countries have implemented, like Bhutan, Malaysia, Brunei, Dar es Salaam, Uzbekistan, and United Arab Emirates. Other than that, nobody has introduced at a national level. In Africa also, access has improved, but it is still much lower than in Latin America. The countries have enormous negotiating potential at the moment. What South Africa has done is very interesting. They have negotiated the prices, so they have considerably, it's not a Gavi eligible country, so they have considerably cheaper prices than the developed countries pay. Similarly, Brazil, they have negotiated the price, and they have also, I understand, the technology will be transferred, so the vaccines will be locally manufactured. And in future, I'm sure there will be more companies which may be producing vaccines like in China and India, and competition grows and demand increases, the price will eventually even further go down. And then again, there are cost effectiveness studies in the context of different countries, low and middle income countries. So if they invest now, they can save a lot of money in future, because it is going to prevent a minimum of 70 to 75% of cervical cancers. It may be even higher, because nobody takes into account the herd immunity. And in fact, there has been a WHO prime modeling study where they showed in 179 countries, if they vaccinate the entire cohort of 11 to 12-year-old girls now, they will prevent in this cohort something like 690,000 cervical cancers and about 425,000 cervical cancer deaths in coming years. Just imagine, this will cost around $4 billion at the current rates. Just imagine, if you vaccinate successive cohorts of girls in coming years, the number of cervical cancers prevented will be quite high. So I think by all the evidence that we have now, the way the prices are coming down, with the negotiating power and things like that, HPV vaccination can be cost effectively introduced in countries. Yeah, that will be a fantastic mechanism. Whenever you bulk buy things, it is very good that PAHO has this revolving fund. The UNICEF procurement office, which purchases the vaccines for the epi vaccines, as well as for the Gavi, the HPV vaccine, how do they negotiate? Because they buy it for several countries. So it's a bulk purchasing. So I'm sure, in Africa, if these countries find a solution by a consortium or something, there will be an interesting approach for HPV vaccination. Now, at the moment, I would say, if you vaccinate girls and achieve a good coverage, and with herd immunity, I think that is sufficient. I think I would like to give a dogmatic answer. And I also forgot to add another thing. Now WHO recommends 2 doses at 6 months apart or 1 year apart for girls between 10 and 14 years. So this also brings down the cost. The cost with vaccination is not only the cost of the vaccine, but the delivery costs. So this is another thing which is now improving the feasibility and the cost effectiveness of HPV vaccination.